Okay, we're back with LLSA 2021 for emergency medicine. Matt Delaney is going to walk us through this article. It's titled The Diagnostic Accuracy of New Troponin Eye Assay and Diagnostic Pathways for Ruling Out MI and ACS by Greenslade et al. Matt, this is, I'm thinking, an important article, seeing that we are using troponin on a regular basis, using clinical decision tools for chest pain. Is this going to change my practice? What's it about?
Man, this one by Greenslade et al. Is a little bit strange. So the idea is great, right? We all see patients with chest pain. We all suspect that they could have an acute coronary syndrome. Over the past couple of years, we've seen really just this increase in the number of proposed ADPs, which is an accelerated diagnostic pathway or protocol. And what Greenslade et al. Tried to do was say, all right, you've heard about these ADPs. Now, we have these new high sensitivity troponins. What happens if we take the ADPs you know and love and then couple them with the high sensitivity troponin? Great idea. The devil's in the details, but let's walk through what they came up with. So they looked at several different accelerated diagnostic pathways. Some of these I was really familiar with, like the heart score, EDACS, EM-ADAPT. But then there were a couple of new ones for me, the new Vancouver Chest Pain Rule and the No Objective Testing Not Rule. So they look at all of these, and this was about 1,800 patients, and it was really two different cohorts of patients who had possible acute coronary syndromes. And all of the patients that were in this cohort had an ECG done and a high sensitivity troponin done at hours 0 and 2. And then Greenslade et al. Took all of this information and retrospectively calculated the scores for the accelerated diagnostic protocols.
I feel like it was basically a competition between all the protocols, and then we're going to add on, well, this high sensitivity troponin, which a lot of shops may not even have yet. So it was this was a lot of new stuff for me.
Yeah, they threw a lot against the wall looking for the primary outcomes here. So several: rate of myocardial infarction at 30 days, rate of acute coronary syndrome at 30 days, and then the diagnostic accuracy of all of the ADP scores. When they looked at rate of MI at 30 days in terms of sensitivity and specificity, you ranged from kind of 96.9 with EM-ADAPT. Heart score, which I think is one we all commonly use, is 97.9% sensitive. But then the Vancouver Chest Pain Rule and the NOT rule were both thought to be 100% sensitive. Now, on the specificity side, not surprisingly, the ADPs that were less sensitive were a little more specific, ranging with the heart of 52.5 up to 67.8 with the EM-ADAPT. And when you got to the Vancouver Chest Pain Rule, while it was 100% sensitive, your specificity was about 29%. In the NOT rule, similarly, you were 100% sensitive, but only 36.4% specific. When you looked at the rate of ACS at 30 days, this is another one of their primary outcomes. Sensitivity, specificity were a little worse, and that kind of makes sense. You're looking beyond just MI at 30 days, and the range was from the low 90s with the EM-ADAPT to the high 90s in terms of sensitivity for the NOT rule. Specificity was higher with the less sensitive rules, like the EM-ADAPT was 69.1%. The NOT rule was only 37.3% specific.
You know, Matt, when we talk about MI and chest pain, we're talking about, like, I don't want to miss, 99% of them. And so when you throw those numbers up there, well, not you, but this paper, I mean, is this a good thing? 100% is as good as it gets for those two new rules. Does that mean basically these are better, or how do you flesh that out?
Yeah, DeClerc, that's a good point. So obviously, if you're looking at a score that's very sensitive, you're going to catch most everybody, but you're going to trade that off for the specificity. So you're going to work up a lot of people or catch a lot of people that actually didn't have the disease. The interesting thing about this paper was that the authors kind of glossed over that. What they really seemed to focus on was the difference in the scores in terms of things that happened after the initial assessment. And they kind of asked this question of, who can go home after going through one of these ADPs? So who can we assess in the ED? Who can we score? And what do things look like after they leave the ED? Now, interestingly, and these were new scores to me, the Vancouver score and the no objective testing, the NOT score, plus the high sensitivity troponin, the authors said that you could find 25 to 30% of people you could rule out for acute coronary syndrome with no follow-up needed. And I had to read that a couple of times. And basically what they're getting at is that both of those scores were designed to say, can we risk stratify patients low enough for these 30-day outcomes that they actually don't need anything after they leave the emergency department? Now, when you looked at the other scores, the M-ADAPT, the ED-ACS, and the heart score, plus the high sensitivity troponin, you could rule out 50 to 60% of the patients at the cost of decreased sensitivity. So you're going to miss a few, but you're going to have a higher subset of patients, a higher percentage of patients that you can rule out. But per the protocol, if you look at how the heart score was designed, was validated, these patients need outpatient follow-up. This is not necessarily something I've always thought about when I'm running patients through these ADPs. I'm really concerned about who can I catch here, who can I send home. But these authors said, look how great Vancouver and no objective testing were, because none of these patients had to do anything after they left the ED. I'm a big fan of the heart score. I think most of us use this pretty regularly. And these authors weren't really that robust on the heart score. So they point out, they say, look, this is a common score. It has moderate sensitivity compared to the other scores that we have out there, the other ADPs. They do acknowledge that if you use the heart score, at least in their data set and in other data sets, that it lets you identify a higher percentage of patients who are low risk. So if your goal is to say, let's not do things for the most number of people, they say, hey, heart might be good there. But your sensitivity for acute coronary syndrome is 95% in this patient population compared to the other scores. And they raise the question of how good is good enough. And they say, look, we have the Vancouver score, we have the NOT score. Both of these were over 99% sensitive in this group of patients, compared to 95% with the heart score. And so these authors kind of say, heart really isn't as good as some people have said on the basis of their scores.
Matt, is this just an example of the newer rules kind of working up, like you said, patients that we may not even be concerned that they're having ACS, or where's that kind of flux coming in? Are they just catching more people that we would not have even applied the heart score to, or we wouldn't even have thought of, like, oh, I think this might be myocardial in etiology?
Yeah, what you probably get is the scores are just a little simpler and they're designed to be more sensitive. So they're designed not to identify low-risk patients. Primarily, they're designed to not miss anybody who has a potential acute coronary syndrome. And again, this is a trade-off with any kind of diagnostics. But I think that's something we have to balance, this catching everybody versus overworking up everybody. Again, I said up top, the devil's in the details, and they give us a couple of interesting things here. They say decisively that checking a troponin alone is probably not enough. Now, I don't think any of us only check troponins in terms of how do we work at patients. We do things like ECGs, we get histories, but they say, hey, if all you did was check a troponin at hour 0 and hour 2, that would be 89.6% sensitive for acute coronary syndrome, which actually, I'm not going to use that, but that number isn't horrible. Now, they bury this in their discussion, but I think it's really important to look at what other studies have shown us about these scores. In this patient cohort, Vancouver had a sensitivity of 100%. There is a similar paper done in a population, I think, out of Singapore, where it was only 78% sensitive. Now, it hasn't been studied nearly as many times as other scores like the heart score, so that's concerning to me, because these guys say it's 100%. Other people say it certainly isn't 100% sensitive. So that makes me kind of pause and say, how good is this information that we're getting in this paper? With the heart score, they talk about how technically the heart score per protocol in a lot of these diagnostic protocols was a troponin at hour 0 and hour 3. This study did hour 0 and hour 2. Maybe that affects the numbers. They don't give us any granular detail there. And they also say that the EDACS and ADAPT scores, when they've been performed on a US-based cohort, have underperformed. So have been less sensitive, less specific. So looking at this, I'm not sure how generalizable these findings are to all patients across the world who could have a potential acute coronary syndrome. All right, so the bottom line for this paper, I think the big pearls for me are that the use of high sensitivity troponin with the Vancouver Chest Pain Rule or the NOT rule, allowed 1/3 of patients to be safely discharged after 2-hour risk stratification. So troponins at 0 and 2 hours, a non-ischemic EKG, and they needed no further downstream testing.
So Matt, this paper was eye-opening because, well, it gave me these other tools, right? The high-sensitive troponin, which, again, not all shops have, and the Vancouver Chest Pain Rule and the NOT rule, which may allow me to get the patient out a little bit faster when I couple it with the high-sensitivity troponin, and without that further follow-up, which my other current rules that I use require. But I got to be honest, based on the data and the paper itself, this is something I'm going to let it stew a little bit longer before I start incorporating it into my clinical practice. I don't think this is the last time we hear about these two rules.
I agree. Interesting takeaways. The LLSA folks think that this is time for us to hear about this, but I think clinically, I don't think this is quite ready for prime time.
This is Hippo Education.